Okay, good morning, everyone. We resume our research and progress rounds. As I'm delighted to have you here, our first talk is on mental health. We have Dr. Mireille Cappelli, who's a clinical psychologist who, with 25 years experience working, specializing in youth and children, as well as young families. He's the Director of Psychiatry and Mental Health Research at CHIO. A clinical and adjunct professor of psychology and psychiatry and a member of the faculty of graduate studies, in case anybody is interested in pursuing some graduate work in this area. So he's considered an expert in his field. He's well sought after for his clinical work, for his as an advisory role, educator, leader, mentor. So he has extensive experience in a wide range of child and youth problems, as well as unique challenges faced by older teens and those emerging and transitioning into adulthood. So you're the developer of the HEADS ED, and maybe you'll tell us a little bit about that today. So it's a protocol that's followed in the emergency room. And maybe at the same time, I'd like to introduce Paula Cloutier, who works with Dr. Cappelli as well. So she's a research associate at CHIO. She has a master's in experimental psychology, and she is part of the services that are delivered in the emergency room for youth with mental health problems, and also has an interest and works in adolescent self-harm. And last, not least, doesn't need a lot of introduction, is Dr. Mireille Saint-Jean, who actually I don't see here, but was the recipient of the Glazier, what was the award called?
The Glazier Award for Youth and Mental Health.
Mental health. So that was, that's an amazing. Yeah, it was amazing recognition of really the applied work that she does. So she's an assistant professor in our department. She has her clinical practice at the family health team at the Civic, keen interest in patient care for those with mental health needs, and is the co-founder of a website which I have visited regularly and which I encourage you to go to for health decision-making, prioritizing, and in terms of decisions for mental health care. So this is primary, if anybody wants it, I'll give it to you after, primarycare.ementalhealth.ca. It's a very helpful resource. She enjoys a collaborative work in shared mental health care as part of the Ontario College of Family Physicians Collaborative Mental Health Network. Former steering committee member and co-chair of the 214 Ottawa Regional and 215-60 Provincial Ontario College of Family Physicians Collaborative Mental Health Network and Medical Mentoring for Addiction and Pain Network conferences. So lots of expertise, an area of extreme importance and very topical. Thank you.
Thank you. Thank you for inviting us to present to your research and progress rounds. I thought we had 20 minutes to present and 20 minutes for questions. The good news, we have 40 minutes to present, so I get the chance to talk a little bit more and give a little more background. I got stuck with the easy part of the presentation. I get to talk about what we've done, and I think Mireille gets stuck with the hard part of the presentation. She's going to be the one sharing with you what we want to do and probably fielding the most important questions. So, Mireille, I wish you luck. I hear you need to have, here in this particular round, you need to have a bit of luck, right? Yes. So, the work that we do, like the work that most of you do, isn't really, a one-person show. It really is a team, and I've just been really fortunate to have Paula as one of my really co-principals on this, and interestingly enough, Sharon Johnson. I knew Sharon indirectly through her husband Roger, who is one of the co-founders of the HEADS ED, and Dr. Zimak, as you know, is an emergentologist at CHIO, and we work pretty closely together to develop the tool. And I also know Sharon through our kids. Her daughter, my daughter, Katie and Vivian, play hockey together. And so, it's just a small community. So what I want to do is chat a bit about the work that we've done in the emergency department and how relevant it is for primary care. And essentially it's really relevant because most of the emergency physicians actually, in some ways, act as primary care docs when it comes to mental health. Most of these kids are the first-time presenters to accessing services, and parents don't know where else to turn, and they go to emergency, and the docs there, basically have to do a lot of the same sorts of things that the most primary care physicians would have to do. So before I start, the tool is called the HEAD-CD. Unfortunately, the way the Adobe thing works, it chose to cut off half of the website, and through repetition comes learning. So in every slide we had the actual website, and now you only know it as the Ottawa Heads, and the rest is up on the board. And I believe that we're going to send out the full thing. So if you do end up learning it as the Ottawa.Heads, hyphen, I'm sure Google is smart enough to fill in the rest. We have no conflicts of interest to declare. And again, really fortunate to have two wonderful teams, both from primary care as well from mental health. So what I'm going to do is spend a few minutes talking a bit about what the, where we're, what the evidence is showing so far, the sort of work that we've done on the HEAD-CD, and then I'll pass it on to Mireille to talk a bit about what the objectives are of the study, the actual details of some of the studies, and then hopefully have some time for some feedback and some, constructive questions. I think we all know what the statistics are for child and youth mental health, that about 10 to 20%, depending on which studies you look at, identify kids as at least meeting one DSM mental disorder. Only about 1 in 6 children actually try to obtain services of those who are identified with the mental illness. And interestingly, with youth, we're seeing those numbers creep up levelly now to 1 in 3. So a lot more youth are coming in for help, and I think that's a lot of the work that's being done in the de-stigma campaigns and youth saying this and this is important, and they are seeking out help, which explains our huge wait list, which explains our number of kids coming to the emergent, probably explains why you're probably getting a lot more kids self-identifying with anxiety and depression and other sorts of mental illnesses. We all recognize that primary care physicians are the first point of access in the mental health care system. It's not us, it's you folks. And I know that the evidence today is clearly pointing that upward direction of more and more youth and children and parents trying to access mental health services through your care. Again, much the same way as we found with our emergency docs, there are some real challenges that you folks face in terms of how do you manage kids and youth who present with mental health problems, and some of it stems from the training or the not sufficient amount of training that folks get. I think everyone is spread with a tremendous amount of things that you need to learn, whether it's in primary care or psychology or psychiatry, and I think it's just time limited. And the other thing that we also find both in primary care as a lot of the other specialties, is that even if you identify kids who have primary care problems, it's often difficult to know where to send them to. So unless you have your roster of folks that you refer to, and most docs don't know where they ought to send, for services. Interestingly enough, when we had and I'll give you an example in the emergency department where it's not just emergency physicians who work, as you also get the psychiatric consults for kids at greater risk. Most of our mental health folks didn't know where to send kids to. So it's so interesting, it's not just, at the MD level, even at the MSW level, at the PhD level, and for some of our psychiatrists, wouldn't know where to send a youth who presents with a concurrent disorder, or a youth who presents with a dual diagnosis, or a youth who presents with transitional AD. So the first place that we decided we needed to start with is how to develop a tool that would help guide both the assessment as well as the follow-up disposition of care. If we're going to develop a tool, and a psychologist and mental health, we develop tons of tools. The problem with most of the existing tools that exist, simply aren't user-friendly. So It doesn't matter if you're working in a busy emergency department or you're working in a busy family practice. The reality is that the amount of time that you have to do the basic assessment and triaging is pretty limited. So the first thing, there are a couple basic criteria that we set out that we thought we needed to absolutely have in place in order to develop anything that would have any kind of uptake. It had to be very brief, easy to administer, it has to be easy to score. It requires minimal or in fact no training at all, so you should be able to pick it up and it should be clinically intuitive. It has to really, at the end of the day, not just be easy and easy to score and clinically intuitive, it does have to help in clinical decision making. It has to be able to use a language that we can all communicate with. And it still has to be a good tool. You need to establish that it has good solid psychometric properties, that whether it is myself who uses, or Mireille, or Roger, or Sharon, anyone, that we all will ask the same questions and get the same answers, leading us down the same path. So the tool we developed is called the HEADS-ED. And it basically, the background is that the HEADS, I'm not sure if folks are familiar with the HEADS was originally developed way back in the US as part of a psychosocial screening. So rather than reinvent the wheel, we took what already existed and formatted it in a way that made it a little more standardized and a little bit more structured in its ability to generate some meaningful outcomes. So H stands for home, E is for education, A is for activities and peers, D is for drugs and alcohol, S is for suicidality, E is for emotions, behaviors, and thought, and D is for discharge resources. And along the top, you can't see it really, this is an awful screenshot of it, but I think if you go to the website, like I said, it has to really just guide you through it without any training, and you just pop it open and you just start hitting things and it makes sense. But essentially, the way the tool works is that it assumes that you have clinical skills already, that we're not telling you what questions to ask if you're going to ask about home. How's life at home? You ask that question all the time. What it then tells, what it kind of guides you to think about is whether or not there's enough problems at home that there's really no action needed, that things are okay. One, that there is some action. You ought to do something, but it's not something that needs to be done immediately. And two, that it should be something that we ought to deal with immediately. So the family's in chaos, and again, there's lots of dysfunction, there may be abuse, and something that you need to deal with immediately. Pretty self-evident. When you actually score the tool, it tells you, it gives you your summary notes, it rates it, it tells you whether or not you ought to have a psychiatric consultation, whether or not there's a need to, where the need is to go on to more tertiary care, or whether it's something that can be managed. It tells you then within your community, whatever area you're in, it will tell you what resources are available, and we keep fine-tuning those resources so that it makes absolute sense. So the one thing that we noticed working with children and youth, that if there was a problem in school, it would punt you back to the school boards. But a lot of the kids we're seeing are 17, 18, and now the 17-year-olds are at university and college, and it wasn't punting it back to the colleges and the universities, so that has to be added. And so I always bring up the drugs and alcohol because that's the one that most folks don't know where to refer kids to, interestingly enough. It gives you the print options, it lets you email, it lets you, so the parents walk away, in the emergency department is really important because you may not see them again, but at least they walk away with here are the resources that you want to connect with. So, what have we done so far with the tool? So the first thing we did is we piloted the tool in the emergency department. We had 313 kids were administered the tool by the emergentologist. The study was done a couple years ago. It was published in Pediatrics, and essentially we had really good inter-rater reliability. And what was really interesting is that in the original pilot, what happened was the tool was actually completed by our crisis workers who have tremendous, lots and lots of clinical experience. This is what they do. In addition to doing the HEADS-ED, they also completed a 1-hour-long structuredized interview, which is again has lots and lots of psychometric, validity to it. And essentially, the 1 hour interview was not any better in terms of the key indicators than the 5-minute head ZD. And not only that, the scores on the head ZD were able to independently predict whether a child was admitted by a psychiatrist or not admitted by a psychiatrist. So they had no idea what the scores were. So we knew that the tool made kind of sense. The next thing we did was we wanted to see, well, that's great. We know our crisis workers can do it. And we know we can do it in the emergency department. We know that it helps guide decisions and helps guide resources. But if we were actually going to implement this so physicians could do it, urban, tertiary, and rural hospitals, clinicians, and it identified a number of things that we needed to do in terms of the environment to help implement the tool. And why I think why this is important, I think Mireille will get to when she presents. And then lastly, the study we just finished and we just submitted, and we submitted PCARE, and the journal just came back with some suggested revisions, so hopefully they'll accept it. Usually that's a good news, as we're trying to assure Mireille that if they're telling you, hey, revise and resubmit, it's positive. If they tell you, try again, not so good. So this time we actually used our emergentologist. We had 639 kids were screened using the HEAD-ZD tool, and independently our crisis workers also completed the HEAD-ZD tool. And essentially the concordance was between 62 to 93%, and the highest was suicidality, which we kind of know. I think most emergency docs, and you folks can identify when a child needs help because they have some suicidal thoughts. We don't have to do safe talk here. I think that's the one question we are very comfortable in asking. But we also had really good sensitivity, not bad specificity, and a positive predictive value of 86%. I should let you know, as I mentioned at the very beginning, none of our ED docs got any training. There was no workshops, there was no, here's how you do it, let's do some simulations, have some pretend patients. There was nothing. All it is the form. At CHIO we're still using we've just gone now to the digital format. We were using the paper version of the HEAD-ZD, which now became, I went through the paper committee of the hospital, where now it's a legitimate tool and it can be included in the health chart. And so it was just, they just get the tool, and it's on the youth's chart or the child's chart, and they complete it. No training. And so it did a really wonderful job of predicting whether or not you ought to discharge back to the community, whether or not you ought to, whether or not you should ask for a consultation or referral on to more specialized services. And it also predicted whether or not the child should be admitted given the scores on the measure. So where's the tool at currently? Well, I can tell you that we decided way back when we originally developed the tool that we weren't going to put any barriers to using the tool. So it's a bit of it's wonderful because basically we're saying it's a completely open access, use it if you like. But the problem is we don't know who's using it. Mostly we don't know who's using it. But here's a few people that we do know are using, because they told us that they're using it. Clearly we are using it in our emergency department. It's been adopted by the Provincial Council of Maternal and Child Health in Ontario for their emergency department clinical pathway. So it is a tool that they recommend as part of the ministry's pathway. It's being used in an urgent care clinic. It's being used in the school board, so if a child in the school is being seen by one of their mental health workers prior to coming to CHIO, they also do the heads ED on the tool so that they can communicate with us where things are at with, how the child or the youth is functioning. It's currently being used. We're actually evaluating the pathway that the council suggested, and the funds are coming from the Ministry of Health and CIHR. We're doing it at CHIO, we're doing it at Winchester, we're doing it at Cornwall, and at the Queensway-Carleton. Provincially, we know it's now part of the tools that are being used at sick kids in their emergency department. It's used at St. Joseph's, it's used at Toronto East General, it's used in the community in Toronto as well, Eastern Metro Youth Services. It's used up north in Timmins. It's currently being used in Nova Scotia at the IWK hospital as part of their intake to mental health services for the entire hospital. It's being used in Interior BC Health, and it's also being piloted in the Northwest Territories. Nationally, it's also being used as part of the surveillance for kids who present to the emergency department who self-injured. Paul is one of the leads on that particular project. Internationally, we know that it's used in a number of hospitals in the UK. It's advocated by the Nursing Association in the US. And most recently, the American Academy of Pediatrics Committee on Pediatric Emergency Medicine, the American College of Emergency Physicians, and the Pediatric Emergency Medicine as part of their, there's a huge clinical report published to pediatrics recommended that heads ED be used as part of the screening tool. We should have marketed it, we should have licensed it, we should have made some money because we never thought about, if it does go somewhere, how are we going to keep funding our projects? But I think that we disclosed that already, that none of us are making a penny from the work that we're doing. And ultimately our goal is to get the tool used as much as we can, because our goal is to have kids assessed in a thoughtful way. And now I want to ask Mireille to present the hard part of the pass the baton. I didn't drop it.
I like the way you leave the more novice person to do the hard work. Yes. But I know that I'm...
Oh, in the box, I've been told.
I'm with a very strong team, and I couldn't think of a better team to be diving into the world of research. Thank you very much, Mario and Paula, for the opportunity. And I also know that I'm well surrounded by my colleagues who are here who are well experienced in research in primary care. And I know that you will not shelter me from feedback that will be useful to advance this project, because this is why I am here today. Even if, criticism, positive criticism to move projects forward do hurt sometimes a little bit. There are links between maybe what I've done would be called research is certainly a tool, but the Daniel Glaser Award was about putting together, it was a seed fund that I used with my husband to start up eMental Health primary care portal a number of years ago. And it's still actively being worked on, and in fact I've managed to involve my residents in training. Probably we're looking at the number of 1, 2, 3, 4, 5, 6, 7, 8 or 9 scholarly projects in mental health have been web pages in the primary care portal. They're reviewed by peers and colleagues in mental health in and around Ottawa, and so that they have a certain richness and validity. I'll have to speak to Claire at one point, how do we set up a proper editorial board in order to really make it peer reviewed. But we try to be as solid as we can in making sure that the information is there that is good and useful to communities. And I will be putting up the link for you at a later point. So just wanted to let you know that there are some links, and the link is also, if I'm still correct, for the most part in and around Ottawa in the Champlain-Lynn. The Heads Ed project runs off of eMental Health, eMental Health, in terms of its database to draw off those community resources that clinicians use. And it's an ongoing evergreening process in that we need for you to feed back to us when things don't work exactly as they should and they're not bringing those resources that are the most useful. Because that's how we make the product better as well. So we'll just move ahead to the next slide. which is the study that we're proposing to do at the Ottawa Hospital Academic Family Health Team, civic site, otherwise known as Melrose, where I work as a clinician teacher, and I supervise residents and look after medical students who come through our unit. We would like to adapt the HeadZ tool as used, as developed by Mario and his colleagues at CHIO, to use in a primary care setting. And what better place, a place where people are excited about learning and research. So we plan on adapting it for use in primary care. We'd like to implement and evaluate its usefulness in using electronic formats, because that's all what we're all about these days. I mean, we have an electronic medical record. We use the computer for the up-to-date. We use it to access all sorts of knowledge and publications. It's also a good place to access a tool, an online tool. Patients seem to like it, but there are challenges and barriers that we will certainly learn about. And that's part of also the project, is when we integrate, we also find about the barriers. And we'd also like to know more about our teaching unit, the practice that we do have at the Ottawa Hospital Academic Site Family, the Academic Family Health Team at the Civic Site, is who are our patients that are children and adolescents that present with mental health challenges to our primary care practice. We'd like to know a little bit more about who they are, how many there are. Are we overestimating? Are we underestimating? Are we just about right? It'd be interesting also to know how we compare to other places in the community. So that's the study. So our methods, we're planning on using a mixed methods perspective cohort with 1 month caregiver follow-up. And I think this is probably based on the framework that you used with the HeadZ in its initial testing at CHIO. We anticipate the duration of the study or the research piece to be about 18 months. And we'd like to be very inclusive of all who provide care to children and youth at our family health team. So we'd like to have the physicians who care for patients there involved, the residents who see many of our patients, and the allied health, those who the patients cross path. In particular, I'm thinking the social worker and perhaps those in the mental health team would be key people to have as allied health on board with us. Patient population, we're going to look at the ages between 6 and 18 years. And this is the cohort that's looked, the original HeadZ tool assessed as well. Although I think sometimes it'd be interesting to look a little further ahead. Those transitional years are particularly risky years, but that's perhaps a tool for the future. So primary outcomes for assessing barriers and facilitators to tool implementation. We plan on using the theoretical domains framework and identify which of the ones of the 14 domains need to be addressed for successful implementation. Is everyone as familiar with the theoretical domains? So I actually looked them up because I knew them vaguely, but and Mary can correct me if you feel so, but there are such things as knowledge, skills, social and professional role and identity, that's beliefs and capabilities, optimism, beliefs about consequences, reinforcement, intentions, goals, memory, attention and decision processes, environmental context and resources, social influences, emotions, and behavioral regulation. So these are domains that present challenges to successful implementation of a project, of a tool. And there may be particular ones that present as challenges in the implementation at our own teaching unit, my teaching unit. So primary outcomes for implementation, ratings of tool utility in guiding psychosocial assessment and decisions around patient dispositions, and percentage of time the heads ed was completed by patients, parents, and clinicians at the Ottawa Hospital.
I'm just going to comment, I should have deleted
You should have deleted because
patients and parents.
Yeah,
That's a
because
different project.
we were gonna think of a little bit of a broader project, but we decided to maybe make it a little bit more concise in view of applications for grants. But initially, the thought was to have, should I mention it or should we wait?
Well, I think we're not going to bother mentioning because we're not going to be doing it.
We're not gonna be doing it for now. So secondary outcomes for implementation. Patient, caregiver, medical staff perceptions of and satisfaction with their primary care visit for mental health issues. The medical staff satisfaction with using the tool. So a tool for successful implementation needs those who are providing the care to be on board and happy in the use, otherwise the tool does not get used. And getting at those demographics of who our patients are. And so we also would like to know a little bit about what happens to the patient, and that's a little bit why we do the 1 month follow-up visit, as to how helpful the use of the tool was to the patient and the families for whom we applied the tool. So the reasons I feel that we can do this, and this is a doable project at our teaching unit, is it's relevant. We know there are children and youth in our population that have mental health challenges, and that we need to find tools and ways to better service, better help them out. I know from experience since Shared Care, Dr. Kathy Gillis and Dr. Doug Green have come on board. They've implemented some standardized tools in providing care to our populations, our adult populations primarily, but we regularly use the GAD-7 and the PHQ-9. And I find it's a great way to communicate between individuals because it's a standardized, validated tool for the assessment of symptoms of depression and anxiety. And here we have a tool that's developed at CHEO that's been validated, that's been proven reliable, that we can test to see if it also works and can provide better, I almost need water, better care to our patients or children and youth. Six glasses of water, that's the first piece of feedback. Wonderful, keep that in mind next time. And it's also an opportunity for us at the Ottawa Hospital to have a collaborative piece with CHEO. CHEO has a strong tool, and it's an opportunity to try it out in our teaching unit, and I think that is great, because I'm all about collaborative work. So I think we're rolling.
Here's your collaborator.
Excuse me. Yeah.
When you're talking about implementing the tool, does this include like the web-based one where you get the specific recommendations?
Yes.
Because at CHEO, I guess it was not, at the Emerge, it wasn't necessarily that, it was on paper, right?
It was originally a paper-based, and now we're moving to the electronic version. Even nationally, with public health and our surveillance is moved electronically on the clinical pathway. It's all being moved electronically. So what we give folks the opportunity to pick, but I think we're going to really, the paper one won't lead you to services. That's the huge limitation.
The tool that we plan on trying at the Ottawa Hospital Academic Family Health Youth Civic site is the electronic tool. Yeah.
So we're just 1 month away from the current study where we're comparing the paper pencil versus the electronic. So we're just wrapping up that data collection.
In which study? At CHEO.
So ED,
Yeah, are you at the?
And then are you electronic with recommendations?
Yeah, so I just want to know if we're actually opening this up for discussion, or
This
whether
is
you
the
want to wrap
last
this up.
slide, and then voila.
Okay. So, did you want to say anything else about the last slide, or?
Well, this is where we're heading.
Okay.
We are in action mode to apply for the TAMO Innovation Grant. and also a CIR, CHI grant. So when we dive, we really dive. Yes.
So I think one of the things that you'll probably noticed when it was presenting that we didn't really, that there was no, we talked about samples and power size calculations and things like that, because I think, we were also very mindful of the amount of time that we had, and we wanted, so there, we do have, what the samples are gonna look like, and we're not gonna submit the way it looks here to a grant committee, because, chairing grant committees, I can tell you this grant would not get very far. So,
Yes, Kevin.
Do you want to take notes? I suspect there's a lot of feedback and interest. Sounds
You
like a
know,
great.
that would be really good.
Just give it back to me at the end, 'cause I've got the other half of my life
the grocery list was on that.
Yeah, I'm telling you, if I don't get the food, I'm in trouble.
I think this is an exciting research. It's
If
really.
you can identify yourself for our sake.
This is Dr.
Kevin
Kevin Potty.
Potty.
Yes.
I'm a medicine researcher, and I think this is really exciting, and I really like how you've developed this tool. But as a CHR grant reviewer, which I am, the thing that's going through my mind is either I missed this, but I missed the prospective evidence that this tool makes any difference in patient-reported outcomes. And I guess if I see that, I'm interested in the rest of it. If I don't see that, I'm saying, you better do that, because how are you going to do the spin-off research if you don't even have the core evidence? So maybe you just didn't present it.
So I think Kevin, as a chair of a CI.
I just want a quick, do you have any RCTs on this? Like, we usually in the guideline world and grade, when we want to promote something, we want to show it makes a difference and there's more benefits and harms. And I guess I just didn't see that.
So there were the two manuscripts, the one that was published in pediatrics and the one that is just going to be published in PCare. Both are prospective. They're both cohort based. They both demonstrated the predictive, validity of the tool. They both looked at the sensitivity and specificity. I think the question that we always face isn't necessarily the most important question that we always face is what's your outcome. And is it satisfaction? Is it uptake? Because most people want to be able to see, does the tool then help not just assess, but does it also help increase uptake of services a month down the road? The problem that you have is we can't, you can't force uptake, because uptake is determined by wait lists and things like that, right? So the real issue then is not whether or not they take uptake, but is do they know where to go, and have they tried to access uptake, and have they felt satisfied with the services they got? And then a bunch of secondary ones that can emerge, the secondary outcomes, which I think aren't terribly useful, are things like wait time in the emerge, even the repeat visits to the emerge. I don't think that's a terribly relevant outcome. But I do think, Paula, you want to?
Well, I think to address one of the comments you had in terms of RCT, and we had entertained that, but
Yeah.
it's very difficult because the measure is out there. Within our institution, people use it. So you'll see on a chart sometimes they don't have the form, but they'll just write the letters down in the chart, and you know they've done the hit CD, and they'll have the number beside it. So it's very hard within our institution to have a group not say don't use it anymore if they have been using it versus. So it would be to find an institution, an ED, where no one's aware that we haven't been using it. But it's also to take into account the head's assessment is often taught in medical schools, at least through the US and more in Canada, I understand. So some people do, they might not do because we put the action levels that's associated with it. The assessment, you can ask the questions that you would typically ask to ascertain the need for action in different areas, the key areas. So it's to find someone naive to that whole thing would be difficult to do. Does that kind of answer? And I'm not saying that we're still not going to
The other thing
critique on
is that
it.
in our first CHR grant on the initial development study, we had looked at doing some sort of randomization between hospitals and it just we ended up not going that way. We ended up just doing more of a naturalistic cohort with a baseline beforehand. What were the number of kids and what was the like services before, and then what happened post-implementation. And I think at the end of the day, probably clearly not not graded to the same level as an RCT, but the evidence still nonetheless shows that it is it's a useful tool. And that's the RCTs would be nice.
So you're looking for that outcome, does it change?
Well, I'm also in the task force, and this would not make it through the task force at this point,
Right.
because we wouldn't be able to put it forward. But I was thinking I was going to bring it to them, because I'm thinking if this actually does work, I would like to promote it, but you guys don't quite, it's not your fault, like, this is a common scenario you're in. It's
Yeah.
nothing to do with your work, right?
Yeah.
And actually, I do believe it's going to be important for family medicine, so I want to shut up here and let other people.
And I think your first step may not need CIHR. Tohama was the better one. You're looking at true
Oh yeah, it's
innovation.
not going to go to
It's
station.
high priority, it's the mental health, it's reducing the ED visits, you are, what they're talking about. So I think that would probably be your best source of first pass funding. And you used it as primarily to describe, did I interrupt?
It's okay, you finish and then I'm gonna help that.
No, I just realized it's like,
No, I'm just seeing hands up there.
then I'll shut up. You said you were using it primarily to describe the population coming in, right? What are the numbers and the characteristics? I also think that you could, if you're actually implementing it,
Visit to primary care, physician is to actually then, make that call to the home and find out what services they have accessed. What was their level of satisfaction with those services? Have they come back to the emerge or back again to the family physician for the same reason? We're looking a bit at that, probably not, may not be what you're thinking, Sharon, or
sounds the same.
sounds.
That would be from the patient's perspective, where you need to get their uptake, their satisfaction. But you can also look at the chart audit trail, where you're in an interdisciplinary team, there are very natural things, plus you've linked it to a list of resources. What was communicated that they should be following up? Is it with family health services, or, because if it's not done, nothing's identified, or you're comparing it to the before, it's going to be a lot less at the linkage and the referral. And you could look at what are the patterns that shake out. That is the start of your outcome.
So in the emergency study, it said that when we compared to a naturalistic, where there is no, it's about a 30 to 40% uptake in terms of recommended services. When you do the heads ED, it's about an 80% uptake. So that was one of the one of the outcomes we were using that when we were trying to do a power calculation, saying, well, this is
That's an
huge
outcome
effect,
of family medicine.
That's
So
a
primary
particular
care.
community resource.
that they actually contacted. They remembered who it was and they made the contact. They may not have gotten the services, but that was.
The other outcome that would be interesting, since we are in partnership with CHEO, is how many children are seen at CHEO as a result of
We'll be looking at that.
use of the heads ed within our unit, and what exactly has happened to those children within the framework of CHEO.
Just well, three things, I guess. One is Simone's project. Simone's working on a project that has a lot of
We'll connect.
Similarities.
to share like uptake of services in the community. So I think and
Yeah.
you've certainly thought a lot about that.
Yeah.
The theoretical frameworks for
Something, yeah.
design behind us. Yes.
Simone,
So she would be amazing to talk to you about that. Another thing I was curious about was it is going to be hard. Oh, I'm sorry. It says
That's
about
clear.
kind of family
That's
medicine.
clear,
We
okay.
share lots of patients, Mireille. Is when we're thinking about outcomes, right? Is this an opportunity to think about like patient-oriented outcomes, right? Like if the families feel more empowered, or they feel more connected to their service providers, or something, like, does that matter, right? Maybe it won't. It's gonna be hard to measure something like suicidal outcomes or admissions or something, but is there some patient-oriented outcome that would really be meaningful in primary care? Might be worth like a focus group or something to think about that or to talk about that, like.
Well, there's the SDQ, not SDQ, the, I'm trying to, I'm trying to think, there's a little acronym and it's 8 questions. And it asks questions like, very similar to, were you happy with your visit? And in terms of, a few of them are more specific. If you had the same type of issue, would you go back to the same service to get help? So it touches a little
like
bit,
that,
and it's a
I'm not
validated
sure.
questionnaire, CSQ8, that's what it is.
Sure, my third point just was that, because I don't want to get frustrated. I'm just thinking about the Civic and how difficult it was for them to implement e-consult as a separate electronic platform to use in care. They really, like, shockingly low uptake for something that was proven to help patients, right? So just thinking about that aspect.
Do you
right?
mean with the Ottawa Hospital and its information technology?
No,
Or do you
I
mean
think
the
it was that,
actual
like,
teaching
I remember
unit?
there's a resident presentation last year on uptake of e-consult at Melrose, and it was like abysmally low, and they basically had to have a resident doing it for them. So
that
they were
was-
getting like 2 consults a month.
Okay.
So just being super aware of that.
That's why the very important first step of the theoretical domains framework to tease out the barriers and facilitators. And then Susan Mishi and her group out of the UK have also done a really good job at mapping on behavior change techniques, like 138 different validated ones, to the different domains. So it gives you key areas to start of what you can work on to address particular issues.
So this was site specific, because if we look
Yes,
at the other
yes,
site,
yes.
instead of maybe IT implementation, like it wasn't as easy to feed into the EMR, but the uptake was, hundreds of consults different.
And
It always
everything
has
is,
to
you're
be
connected with Jeremy Grimshaw's group, and that's the kind of thing they look at, right? So that's
Yeah.
part of the implementation, is the e-tool the best thing for this practice? Should you give an alternative and so on?
Well, that's what I was thinking, Claire, when you asked about the paper version, now that you brought up, was that kind of your thinking behind this?
No,
Was
I
the worry that the
No,
electronic
I
wouldn't
wasn't
be?
actually, but you're right. And I don't think, I'm not sure if full paper might be because of EMR so bad, but you could speed it in after, but then you won't get the service.
You won't get the
But anyways, I
service.
just wanted to raise it because I was thinking of the uptake there, that was a real challenge I thought.
At the particular site, I think, in having been at Pacific for 10
Yeah,
years,
you'll be on.
and in knowing the people who I work with, I think it's a lot about building relationships that work and encouraging and supporting people. And I think when you are there, you might have a net advantage in that way. And that might be the reason why, because Claire, Liddy was situated at the Riverside.
Across the province.
Yes,
Melrose is worse, right?
Yeah.
So
yeah.
just like thinking about that, but it might be
But it-
actually really to Kevin's question, how can you convince people it's gonna make a difference for them?
Yeah.
Yes.
Right?
Doug Archibald, education researcher here at the department. And Mireille, first of all, it's great to see you up there. And so this is fabulous. And I just wanted to pick up on a comment that Sharon made about the your 2 targets for applications, the Tahamo and the CHR project grant. And these are 2 different beasts for sure. And I think with the Tahamo, it's really innovation, and I'd echo that sentiment. Going for that, as an innovation. And something that I sort of picked up, I didn't see in the slides, but I certainly picked up when you were speaking, is identifying the gap. All right, and I think you stated what the problem is, and really getting at the gap for primary care, and making that front and center, before getting into your innovation in the design, and that would be really important, I think, for success, certainly the town.
Good thought.
So I had a comment, if I can chime in here.
Yes, sure.
This is fascinating, and as Claire said, so we have something that aligns really well. So I'm really of that mentality, harness the resources that are available to help those folks. But I'd like to come back to what sort of the discussion's been around is your endpoint, your measurement, and I think it comes back to your objective. So I didn't actually see an articulated objective. Like, what do we think this is? So is it a feasibility, or And when you were describing the validation of the tool, I noted two outcomes you looked at, and I hope I got them right, but maybe not. One was, I guess, admission from ED, and the other one was a referral to psychiatric support. So, you know, these are important outcomes, and it's clear to us, and I guess maybe what Kevin was saying was, well, do these then help with the ultimate clinical outcome? And that's eventually, you want to be able to tie to that. I actually think that the return to ER is an excellent outcome, in terms of, but that won't be for your study, that would be when you're at ED.
Too small,
Oh,
yeah, too small.
The only reason why the return to
Yeah,
visit.
no, but I meant for people who show up at the ED,
Right.
not for the, not
The
for the
only
strike.
reason why that's not an important indicator because when we looked at the kids who come back from emergency departments and in other studies,
Yeah.
they're a very select group of frequent flyers, right? So they're not the 40 or the 50% of kids who present for the first time without any access. I think they're very unique. Only as a side point.
So
But
here,
we'll look at that. No,
Yeah,
we're not
yeah,
excluding
but
that.
as Sharon said, this is not at the practice level. This is only for those high-risk ones who've already been in ER. That might be a possibility. So looking at your outcomes, how would you articulate your objective? So I'm going to bring, you're selling it to your practice. I'm going to bring this tool here because I think it will.
I think it, for me, from where I see it, I first and foremost, I see it as a way of standardizing care and a tool for communication between care providers.
Okay, so it'll help us,
And
so is
and then
yeah, sorry.
it's going to help us pull quickly those community resources that will improve their outcome.
See, I see where we're at right now is really at the feasibility level in terms of whether or not the tool can be actually, implemented in primary care. What are going to be the barriers to implementing primary care? What do the outcomes actually look like in primary care? Do those outcomes make sense for folks here compared to other folks? And are we, in a place then that the tool is sensitive to those, to those outcomes? And if not, then what has to be done? That's why we talked a bit about, do we have to change some of the items on the tool? Do we have to change some of the services? It could be very, very different. So at a very pilot feasibility level is where we're.
Yeah. Who are you intending to screen though? Who is this, like at their annual visit, if they come in with a psychological distress, or anybody?
Well, I think the goal would be, it's to screen any youth who's presenting with a mental health concern between 6 to 8 to be 18.
So that was one of the things I had you're looking at your outcomes, you're describing the characteristics and the number with certain conditions. I think you also have to get the type of visit they came with. And I don't think you can limit it to mental health as a primary complaint in primary care. But I think that the appeal of this is you're addressing a potential gap. We don't know because we haven't studied, is there a serious number of kids out there we are missing it completely? And are they coming in for sore throats or menstrual cramps at 14 and we're missing it? And I think the tool has some really attractive features for primary care because you look at that, it's a pretty comprehensive assessment. We have most of that information, or we should be getting it at some point in the teenage years. So you lodge it in what we do in primary care and maybe potentially addressing a serious gap of not finding the unmet needs. Mm-hmm. That might be low level and this will be the challenge. They're not going to the emerge. You might have very low level and you might have very acute. And you're going to catch it all with this. Mm-hmm. And so then what you do with it. But I think the focus on, should we be screening this comprehensively or just with the 2 questions we use for adults? Because you have all of that information. And that's where I'd say if you look at what you think would change, it would be a better approach to screening. You might look at different implementation pathways for that. Every visit, just certain types, and see what you uncover.
So the one thing that Mireille goes, should I mention it? And I said, maybe not. And where it might be more relevant in primary care and probably less relevant in the emerge are the parent and youth or self-versions of it where, the parent can't complete a screening, a very simple screening, and the youth can, complete a very I'm going to be really,
No, I think
so what
I think it's Lamont
not to you.
No, no, so
I'd
I'd
rather hear
like to
your
actually
question versus
see,
hear myself.
I'd like to see whether there is anyone else who wanted to comment or to ask a question. So Danielle, and then like brief, and Alan, and then we're gonna cut. Okay, quick.
I guess my question is, what do you think contributed to the spread of this innovation? Like, you're saying that you didn't sort of market it to, you didn't provide training, so what did you market it? What pushed it across and so successful? Is it just because there was a gap and there was no other tool? Could you explain?
I
I'll let
think,
Paula answer, our chief marketing
well,
strategist.
I think there was some champions that developed naturally in the ED who liked the tool and would word of mouth tell their colleagues or tell one of the residents, and the residents would tell some of the other residents. So it just
And oddly enough, as you know, we also did it through just typical, you know, going and giving talks and giving academic talks, right? And there's nothing really beforehand, and the tool showed some really, you know, decent evidence compared to no evidence. And I think it just sort of organically went from there.
Thanks, Alan.
Really quick, I'll make you. I work with Cappelli Research Associate. Not my area, and I may have missed this, but I'm a little worried you're going to identify false positives.
Right,
So, and I didn't hear you explain,
right.
do you have like a threshold, do you have a
It's
gold
specifically
standard?
60 something.
So the threshold, if when it's scored, you know, to the recommended cutoff for, you know, secondary, for a secondary assessment is 8 or above. The sensitivity is pretty good, and specificity is a bit lower, and there's a lot more false positive, and I think we were okay with that because that's where we want to err. So if
We could argue that for a long time.
yeah, it's not a huge, but I think it's still, even, you know, again, it's still not as bad as,
Okay.
but that's where there is a little bit more air in that, for sure. Follow you.
So a huge amount of interest, and we're going to take a break, and I'm sure you're going to be available for some discussion. And so it sounds like you're really well surrounded in terms methodologically from the psych aspect and from your colleagues here in terms of the primary
Great
care
feedback.
context. So I'm sure these discussions are going to keep going after, absolutely. And I'm sure everybody who's commented will be keen to continue the dialogue. So we're going to take a 5-minute break, and then we're going to go to our next stop. So 5-minute, what time is it, someone?
9:35.
35 at 9:40 or later, please.
Thank you for the opportunity, everyone. Thank you for
Yes, thank you.